Hey everybody, this is Rusty, and today we're going to talk about abdominal disorders, part 3 of 3. In this section, we'll review abdominal disorders associated with the liver, inflammatory conditions, neurological causes, cardiopulmonary causes, genitourinary causes, and endocrine causes. It's going to be fun, so let's get going. All right, let's get started in the liver and talk about jaundice. Some background. It's due to high levels of bilirubin. Bilirubin is produced when the RBCs break down and get filtered through that liver, and it's secreted into the bile. Causes for adults is bile duct obstruction, liver dysfunctions, and cholecystitis. In newborns, babies just need some sunlight to make them get rid of that bilirubin and turn that skin back to not yellow. So recent histories for your patients could be trauma, blood transfusions, viral illnesses, chronic alcoholics. They just need another drink. Acetaminophen overdose or a lot of usage, and hepatitis. These patients will present with fever, chills, abdominal pain, flu-like symptoms, recent weight loss, pruritus, could be itchy, and right upper quadrant pain. They may have that yellow skin and those yellow eyes. Those yellow eyes are called scleral icterus. Scleral icterus, or yellowing of the eye, or the yellowing of the sclera. Scleral icterus. Man, that sounds like a great test question. Next is hepatitis. We're going to talk about Hep A, Hep B, and Hep C. Hep A transmission is oral fecal route, so wash your hands after you poop. There is a vaccine for it, and if you get it and you get treated, then you have lifelong immunity. Hep B, it's blood-to-blood transmission or sexual contact transmission. If you're a healthcare provider, you should have the 3-shot series for your hepatitis. So there's no cure and no treatments available. Hep C is blood to blood, no vaccines, and is curable with treatments lasting 8 to 12 weeks. So some signs and symptoms with all 3 is loss of appetite, nausea and vomiting, fever, joint pain, dark urine, clay-colored stool. That's kind of odd. Clay-colored stool and dark urine. They may have some jaundice and upper right quadrant pain. Then you got asterixis. That's flipping of the hands. You put their hands flexed out, and they'll start to flap. And then you got acetylcysteine for those Tylenol overdoses to help protect that liver if they try to kill themselves by taking too much Tylenol. Acetylcysteine will help with that. And that's some information about hepatitis. Let's talk about irritable bowel syndrome and diverticulitis. EMS deal with these during flare-ups. So with IBS, patients will complain of abdominal pain, excessive flatulence, either constipation or diarrhea, and those stools will have some mucus. So when they complain of abdominal pain, you've got to check on their bowel and bladder status. With diverticulitis, that is potholes in your colon, and those little potholes get clogged up with blackberry seeds or popcorn and other various things and become infected, and that's why it's an itis. So it's in the left lower quadrant. Diffuse abdominal tenderness, maybe some distension. They're going to complain of nausea, vomiting, diarrhea, or constipation, and it's paramedic supportive care, IV, O2 as needed, and monitor. Some fluids to support a blood pressure, and take them on into the hospital. Next is cholecystitis. This pain is cyclic in nature. It waxes and wanes or comes and goes, and is aggravated by eating fatty food. So the patient can be fevered, complain of that right upper quadrant pain, and that pain may radiate to that right shoulder or straight through to the back, and it could increase with deep breaths. They could also be jaundiced, complain of nausea and vomiting, or just not eating much and anorexic, and fat intolerance. That fatty food, like I said, aggravates this sensation. A test in the field we can do is Murphy's sign. We're going to push up into the right upper quadrant and have the patient take a deep breath. That drops that gallbladder underneath that liver down a little bit, and you poke it and they say, "Ow, stop that." So care in pre-hospital environment is IV O2 is needed and monitor. They're going to need antibiotics for this or the removal of a gallbladder. Next is ulcerative colitis and Crohn's disease. With ulcerative colitis, you've got bloody diarrhea or hematochezia, abdominal pain, joint pain, fever, fatigue, and loss of appetite. Ulcerative colitis, that pain is going to be in the left lower quadrant. So with Crohn's, the diarrhea and weight loss occurs, and it's also bloody, even though the picture says it's uncommon. It's little amounts over long periods of time. They've got weight loss, arthritis, skin problems, and they can even become anemic from that chronic bleeding, little amounts over long periods of time. Pre-hospital care, IV O2 is needed, and the monitor and fluid to support that systolic blood pressure. And with Crohn's, we have the right lower abdomen, ulcerative colitis, left lower abdomen, Crohn's, right lower abdomen, to help differentiate one from the other. Some neurological causes of abdominal pain. Their head hurts so bad, it makes their belly hurt too. Chief complaint may be some nausea and vomiting. Do a good assessment for those head bleeds. Remember, epidural bleeds are arteries, epidural arteries, and they bleed fast, fast, fast. Then you have subdural bleeds from those bridging veins, and they occur a little slower. And then you've got those subarachnoid bleeds, could give you some signs and symptoms of a stroke. So figure that out. Meningitis. Bacterial meningitis has a 25 to 50% mortality rate. So if you suspect it, wear a mask. You and your patient and your partner. So look at all those signs and symptoms in the middle of the page. And if you think they have meningitis, have them bend their head down and look at their new cool shoes. Look at those new cool shoes, and if their neck hurts, they have new cool rigidity. And that's pathognomonic for meningitis. Or they could be nausea, vomiting, because the room is spinning around in circles and they have vertigo. Attempt to isolate the cause. Paramedic care, IV O2 is needed, and monitor and get them on in for evaluation. Cardiopulmonary causes of abdominal pain. You can have an abdominal aortic aneurysm. AAA classic triad is hypotension, abdominal pain that radiates straight through to the back, and a pulsating mass in their belly. Sad thing is, only about half patients show that pulsating mass. Or they can have that acute coronary syndrome. I've got some pain right here in the epigastric area, and they're denying the heart attack. They could be complaining of nausea or indigestion. That acute coronary syndrome can cause the patient to have abdominal complaints. Other cardiopulmonary causes is a pulmonary embolism. May complain of upper abdominal pain. Remember, it comes from that blood clot, normally a DVT, air bubble, cholesterol, lung sounds, and O2 sat, that VQ mismatch. You're giving them all kinds of oxygen and their O2 sat still stinks. They've got a history of long travel, recent surgeries, smoking, birth control, and things like that. Then you have Budd-Chiari syndrome. It's occlusion of the major hepatic vein or the inferior vena cava. It's caused by acute or chronic liver failure. It causes that emergent, sudden abdominal pain. It can cause hepatomegalia, a fat liver, and cause the patient to have ascites and possibly jaundice. Then the pulmonary cause of abdominal pain could be the patient with pneumonia. So try to rule those things out. Of course, do that minimum patient assessment. Look for those, listen to those 6 lung fields, and if they have difficulty breathing, you'll lean them forward, hug themselves, and listen to the back also. Paramedic care, IV O2 is needed, and monitor and get them in for further evaluation. Some genitourinary causes of abdominal pain. Abrupto placenta, a placenta previa. Remember, with those abruptos, the second half of the pregnancy is when they occur. Painful bleeding, dark red blood. With previa, it's painless, bright red bleeding. So, tell those differences. Help. Hemolysis, elevated liver enzymes, low platelets. So with these, look at the signs and symptoms on the page. You may pause this for a moment. With help, you're going to treat with mag sulfate and maybe labetalol. Then you've got that ectopic pregnancies. They're going to complain of vaginal bleeding with or without pain. We're doing paramedic supportive care, IV O2 is needed, and monitor and get them in for further evaluation. Some other genitourinary causes is polynephritis, which is a bacterial infection of the kidneys. They'll complain of flank pain, may run a fever, shaking, chills, and they may have a foul-smelling urine. They may say when they gotta pee, they really gotta pee fast, and it's tender if you tap on their kidneys. You'll do this from the back side of the patient's body, and you tap, and they say, "Ow, stop it." Then kidney stones can cause abdominal pain. It's a calcium buildup, and they feel like they need to walk or bend or twist to relieve that pain. And they may trace that pain from their back, around their sides, and down to their belly. So, and then acute renal failure. Take a look at those signs and symptoms. With these, we're sticking with that basic paramedic care. IV O2 is needed, and monitor fluid boluses to support a systolic blood pressure, and take them on into the hospital for evaluation. Next is chronic renal failure and end-stage renal disease. That's less than 15 milliliters a minute of the glomerular filtration rate. Various signs and symptoms in the body systems on the chart. So pause here and take a look real quick. All right, hey, let's come on back. So they are withdrawn, depressed, they can't move, they don't have ankles, they've got cankles from all the fluid backing up. So pruritus, ecchymosis, purpura, gray, yellow skin color. They can see the end coming. Complications of renal failure is pulmonary edema, hyperkalemia, remember that's potassium, fluid and electrolyte imbalances. For our treatments, if they're in shock, they need fluid. If they have edema, Lasix, pain control with phenol dilaudid. And if they have hyperkalemia, look for those spiked T waves. You think about ALIC. It's like, Russ, what the heck is ALIC? That's albuterol, Lasix, insulin, calcium, and kalaxolate. Albuterol and insulin help shift the potassium back into the cells. Lasix increases renal excretion of that potassium, that loop diuretic. Calcium gluconate helps protect the myocardium, and Kalexolate helps remove potassium in the gut. So when you're looking at that chronic renal failure, you're thinking about ALIC. EMS may get called to assist with home health devices. This could be due to cancers, strokes, gastric bypass, just to name a few. Problems can occur. You just need to remember DOLB. The device is dislodged, obstructive, leaking, or bleeding with these. NG tube, do an exam for aspiration or choking, and flush as needed. That trans-abdominal feeding tube, examine that for infection at the site, and DOLB. So bowel ostomies, those need seen at the hospitals, just like the ports of your dialysis access and things. Basic paramedic care, IV O2 as needed, and take them to the hospital. Remember that good primary assessment, that GLT. It's easy as A, B, C. Then you look at these, expose these for an exam, and set your priority for transport. And then a good minimum patient assessment. Get that temperature, texture, color, the skin, the pupils, the neck for JVD, 6 lung sounds, 3 heart tones, pulse wiggling 4 times 4 extremities, and pedal edema. Rule out any serious signs and symptoms, and do that IV O2 as needed, and monitor basic paramedic care. Older patients have slow metabolisms and gastric motility and may have inadequate nutrition. Good, reliable history is a must with our older population. Our bariatric patients may have gastric bypass or bindings, and those procedures have a risk of complications. Do an assessment and basic paramedic care. Our OB patients, think pregnancy for any female in childbearing years complaining of abdominal pain. Remember, with our abdominal diseases, the rule of thumb is consider more causes and work towards less common causes of those abdominal complaints. They are your #1 patient, so use your #1 finger and have them point at the pain. And remember IAPP. Hey, we're at the end. Everybody's favorite slide. We're part 3 of 3 of abdominal disorders. I hope you enjoyed it. Have a great day.